we have to intubate and keep on ventilation. The role of antibiotic in bronchial asthma. There is no role of antibiotics in bronchial asthma because by habit some people may give, but it is an inflammatory disease. What we need is bronchodilators and anti-inflammatory drugs. Antibiotics are indicated only when there is a secondary infection, when there is a strong evidence, patient has high fever, leukocyte counts are more, there is a patch of pneumonia or pleural effusion. It is only then that the antibiotics are indicated. So that is all about bronchial asthma. I think we'll talk about COPD for next 10 or 15 minutes. So COPD is again cousin of bronchial asthma, almost causes, presentations, treatment, everything is almost similar. So what is COPD? Chronic obstructive pulmonary disease. So this is the chronic, COPD is a chronic disease, bronchial asthma is intermittent disease. That's the difference you have to know. So COPD is gradually progressive. There is a permanent damage in the, on the site of the defect also. I'll just come to the whiteboard again. Arbaz, can you help me? So we are coming to our good friend here, alveoli. Okay. The asthma is a disease of airways. The disease is the airways are inflamed, they are swollen, the mucus plugs are there, and bronchoconstriction is there. That's why you get wheeze, musical sound. But now COPD, the disease is here. Maybe here, maybe here. COPD has two components. One is chronic bronchitis, emphysema, and bronchiolitis. These are the three components of COPD, chronic obstructive pulmonary disease. Chronic bronchitis, more commonly seen in smokers. So one of the very important cause, etiology of COPD is smoking, chronic smokers. Because as I told you, smoking damages the epithelium of the respiratory system. So we have three components, chronic bronchial asthma, emphysema, and bronchiolitis. And chronic bronchitis. So chronic bronchitis is here, same almost like bronchial asthma, the inflammation and sputum production. So even you can separate out these two with the history. So if the patient comes and says that I've got breathing, difficulty in breathing and severe cough with lot of sputum. If the patient gives you a history of cough and sputum for 2 months in 2 consecutive years, that is the diagnosis of chronic bronchitis, especially in a smoker. Whereas emphysema, they have gradually progressive breathlessness. The sputum production is very less in emphysema. That is a differentiating point. But in a given patient, almost every patient have both coexisting. You cannot have just chronic bronchitis or emphysema. In a given patient, they coexist most of the times. So when you come to emphysema is the disease of the alveoli. What happens is this beautiful shape of a group of a bunch of grapes is distorted. It becomes something like, can you see? It becomes something like, it becomes big and irregular. It becomes, this will become like this. It becomes big and irregular, destroying the elasticity. So we have elastins and anti-elastins in the lungs. These are the chemicals, elastin and anti-elastin. So the anti-elastins become more, elastin become less, and the elastic, the recoiling, what we call is a lung recoiling mechanism gets disturbed, and the exhalation becomes difficult. That's why they have difficulty in breathing during exhalation. So expiration. So that's why the bronchi also more hard. This is the reason for that. The CO2 gets retained. The patient will not be able to breathe out properly. Whatever amount of air is coming, it's not completely going out each time. That's why patient will have a difficulty in breathing. So that is the emphysema, the damage of the alveolar acidic. The architecture is distorted. Okay, as I told you, smoking is a culprit here, unlike bronchial asthma. Again, same bronchoconstriction, inflammation, sputum production, and diagnosis. Of course, it is almost like same. Presentation will be same. Cough, expectoration, wheezing, and triggering factors are also same. Triggering factors will be the same. And when you want to diagnose, you do. If you do a lung function test, same. Your uh, fraction expiratory volume is less, and if you give bronchodilators, there is no complete reversibility. That is the differentiating point between asthma and COPD. In if you do a lung function test, you will know whether the bronchoconstriction is reversible or not. So they give inhaled bronchodilators and see the effect in the graph. The bronchoconstriction will not be reversed completely. Then your diagnosis is COPD. If you read tonight, you will understand the exact difference between these two, and you will never forget the disease. You can easily diagnose in a given patient without any tests, taking the proper history and diagnosis. Again, what are the signs and symptoms? I told you, sputum, cough, breathlessness. Sometimes they may have fever. Again, triggering factors are infection, stress, smoking, some drugs, and all. And because there is a distorted alveoli, each alveoli becomes big, so the whole lung volume becomes big. It is called hyperinflated lung. The hyperinflated lungs compress the heart. I think I have an X-ray to show you. I'll show the X-ray. Compressed from the lateral sides. The enlarged lungs, hyperinflated lungs, compress the heart and making the heart like a tube. So this enlarged lung changes the shape of the chest. Your shape of the chest is semi-conical. We discussed. It becomes a barrel shape. The semi-conical chest will become like a barrel because this hyperventilation, because the damage of the alveoli. So that is the X-ray finding, and heart becomes tubular. This is in advanced stages. And what are the complications? Even this page, they can come with acute exacerbations. Same thing like bronchial asthma. They can come in the night or early morning. They may land into respiratory failure, type 1, type 2. You may have to intubate. You may have to put the patients on ventilator and give